So, like I said, we're going to be doing the pelvis unit tonight. It's our last unit, just a few more muscles to go. And we're in the home stretch. So just stop me if you have any questions. All right, so same old outline. But what you're going to notice in this unit is it finishes off the body. We have a few muscles left to go, namely the abdominal muscles. And then it also acts as a review. So you're going to see some stuff in this PowerPoint that was from the introduction units. So we're going to come full circle, finish off the year. And then what happens is next year, you will be starting the pelvis with the advanced students, right? So I make sure to end your year with what you're going to start with next year. So it's also an introduction to next year. So there's actually 3 things going on. We're finishing up basic anatomy, we're reviewing it, and we're preparing you for next year, all in this unit. So lots going on, but you guys can handle it. So as you can see on the screen, there's an image of the pelvis. So you'll notice the pelvis consists of the 2 innominate bones. So here's one of them, here's 2 of them, this other one, 1, 2. The sacrum and the coccyx. So recall that the innominate is made up of 3 bones that fuse together, the ilium, the pubis, and the ischium. So we studied the innominate when we did the hip unit. The innominate is also called, it has many names, os coxa, coxal bone, and hip bone. So we should, in order to be clear and avoid confusion, when we say the word hip, we should say hip joint or hip bone. Because the hip bone is the innominate, right? Put your hands on your hips. You put them on the iliac crest, right? Most people, if you put your hands on your hips. And that's the hip bone. Whereas if we're talking the hip joint, well, what's the hip joint made of? What do you guys remember? The hip joint is made up of what 2 bones? Yeah, the acetabulum and the head of the femur, or the innominate and the head of the femur. That's the hip joint. Okay, is that part of the pelvis? Do we see it here on this image of the pelvis? Nope. So you got to keep those 2 things straight. Okay, hip joint, and you guys already know how to assess that with APR, right? You guys are going to learn different assessment for the pelvis, for the innominate bones specifically, and then later for the sacrum. Okay? So try to keep those 2 joints separate, pelvis and hip, but you're going to see that there's similar muscles that impact both the hip and the pelvis, okay? And that's okay, that's allowed. The muscles can cross the boundaries, okay? But the pelvis and hip are separate. So think about, pretend it's like a border of 2 countries, okay? So we've got the pelvis on one side, and on the other side we have the hip. So it's 2 separate countries with a border in between. But would you agree that people are able to move between, usually if there's no wall? So the people move between, just like the muscles will move between, okay? May move between the borders. Maybe they have dual citizenship, for example. So they impact both the pelvis and the hip, okay? So that's how it might help you if you think of it that way. Okay. So it's just a review of the innominate bone here. If you have any questions about that, you let me know, but we studied it with the hip, so It's just more images for you to identify the bony landmarks, take a look at your skeleton. We have the inguinal ligament. I believe we talked about this with the hip, but I can't remember. So the inguinal ligament runs from the ASIS to the pubic bone, and it forms the top border of the femoral triangle. The other border of the femoral triangle is your sartorius muscle and your adductor longus muscle. So structures found in the femoral triangle is the femoral nerve, artery, vein, and your inguinal lymph nodes. So they're superficial there at that location in the femoral triangle. So just to review, there are bursa in this area, especially related to the hip, and this can sometimes cause referred pain to the pelvic region. So bursa is just sacs filled with synovial fluid, and they'll grow anywhere in the body to reduce friction. Generally, they grow in the same locations or similar locations in people. There's a specific pattern of them, but if you need it, your body will grow the bursa in any location. Okay, so now we're going to get into the pelvis a little bit. This is where, like for example, when we did the hip, right? What type of joint was that? It was synovial, but what shape, like what type? Do you guys know what I mean when I ask that? Yeah, ball and socket. Good. That's what I was looking for. So ball and socket joint's highly movable because all three axes pass through it, X, Y, and Z. When we get to the pelvis, there's more limited motion, so there's usually only one type of axis. For example, the first joint of the pelvis we're going to be talking about is the pubic symphysis. So that's right here. And there's the primary axis of the pelvis travels through the pubic symphysis, and it's a horizontal or X-axis. We're going to see that there are two other joints that we're going to look at in this unit, the iliosacral, so between the ilium and the sacrum. It's also called the sacroiliac joint, either one. But when we say iliosacral, we mean the innominate is doing the moving. And if we say sacroiliac, it means the sacrum's moving. So for this unit, we should be saying iliosacral. So we're going to find later that there are 3 more axes passing through those joints. So for a total of 4 so far we have. But the primary axis is the one that travels through the pubic symphysis. So yeah, it just depends on which word we say first. That tells, so if we're talking, if 2 therapists are discussing something and we say iliosacral joint or iliosacral motion, we're discussing the movement of the ilium on the sacrum. Later, we might talk about sacroiliac joint or the sacroiliac motion, and that's the sacrum moving on the ilium. So the x-axis is also called transverse or horizontal axis. The x-axis corresponds to the sagittal plane. Does that make sense? So you have to be specific if you say planar axis. X means horizontal, transverse. Y means vertical, right? Or up and down. And Z means coming out of the page. Okay, so the pubic symphysis is an amphiarthrosis cartilaginous joint, meaning there's only some movement available there. Again, I can't stress enough, the primary axis of the pelvis passes through this joint, and it's an x-axis or transverse axis. There's a disc you'll see located between the two pubic bones, a cartilaginous disc. And there's ligaments, the superior pubic ligament and the inferior arcuate pubic ligament. And we're going to see that on the next slide, I believe. Here they are. So we've got the superior pubic ligament, so travels on top or superior, inferior or arcuate pubic ligament. Oops, that box should be circling that. You guys remember the obturator membrane, right? So it's showing it to you here. There's a disc between the symphysis pubis, or the pubic symphysis, and we've got the iliac inguinal ligament. There's more ligaments, of course, but they belong with other units. So we're just going to focus on the ones we need for this unit. Okay, so that was basically the pubic symphysis. Now we're going to talk a little bit about the iliosacral joints or sacroiliac joints, SI joints. Sometimes you've heard of this, right? SI joints. These are synovial diarthrosis joints, and they're underneath the PSIS. So you know when you do standing seated flexion and you're touching the PSIS, right? Underneath your fingers, underneath there is the SI joints or the iliosacral joints. So these joints are located between the auricular surface of the sacrum. So there's an ear-shaped surface on the lateral side of the sacrum, and there's a corresponding ear-shaped surface on the ilium, and they match up. There's not that much motion available, but there is some motion available at these iliosacral joints. So now, sometimes people have difficulty with this unit because there's a lot going on and it's kind of small movements. So what we're going to do is we're going to exaggerate them to try understand them better. We're also going to isolate the movements. For some people that helps because it simplifies things. For some people it doesn't help because it's too simplified and it doesn't actually make sense. It depends on how your brain works. It doesn't matter. I'm going to try to do it both ways so that it'll work for you. One of them will work for you. So we're going to talk about how the ilium moves on the sacrum. So motion at the iliosacral joint is what we're going to talk about. In order for this motion to happen, the sacrum is also going to move. However, we're not going to talk about that in this unit. We're going to save that for later. Okay, so just know that the sacrum will be moving too. But it's just too complicated to talk about it all at the same time. But if you're having trouble picturing how the ilium's moving on the sacrum, just know that the sacrum will do some moving as well. It's called sacral torsioning, but we're not there yet. So through the iliosacral joints, we've got 3 axes, but we only care about one of them. The inferior, approximately at the level of S3, it's a horizontal, transverse, or x-axis traveling through the iliosacral joint. And then, of course, we're going to talk about 2 ligaments, sacrotuberous ligament and sacrospinous ligament. They're coming up a little bit later. Okay, so How are you guys doing so far? Yeah, you might feel a little bit off balance with this unit, and that's normal because it's not really like any other joint we've taken. Plus, all these motions are going to get different names again. Remember how the scapula we had different names for the motions? That's going to happen in this unit again. We're going to take it step by step, and you guys can handle it. I know it. It'll just take some time. And when you feel a little bit confused, probably because that's learning, there's learning happening, and then ask me a question or re-listen to the recording and we can figure it out. So now this image here, what we've done is we've taken the sacrum off of the ilium and moved it ahead. Okay, so it's a disarticulated view. So we said there were three axes. They're transverse, horizontal, or x-axes. So they're represented by the blue, purple, and green. And then, of course, they correspond with the sacrum as well. We only care about the inferior transverse horizontal axis. So I'm going to let you guys draw because I want you to circle which axis belongs in this unit or which one we're going to focus on for this unit. It's the inferior x-axis of the iliosacral joint. Or you can type in the color, or you can circle it. So if you could, just don't use the highlighter. Use a pen, not the highlighter. That would be awesome for the rest of this PowerPoint. That way I can go in with the highlighter and show the correct one. So, ready for the correct answer? Which is most inferior? The green. So that's the one for this unit. The inferior x-axis of the iliosacral joint. Here are the ligaments. So we have a sacrotuberous ligament, meaning from the sacrum to the ischial tuberosity. And then we have a sacrospinous ligament from the sacrum to the ischial spine. All right, so we had that. Oh, that dot's a little moved over. But the main axis of the pelvis is the transverse x-axis at the pubic symphysis. And then we've got the inferior. Oh, I got to fix this. It's bothering me. It's a bit better. Okay, so we've got the two axes, the inferior, or sorry, the main primary axis here at the pubic symphysis and the inferior x-axis at the iliosacral joint. They're both x-axis. So all of these, both of these articulations work together along with the sacrum moving to allow for all the motions of the pelvis. So the motions of the ilium and the sacrum, they all work together. And like I said, we're going to isolate them in this unit. So if you recall, factors that influence actions at a joint. So actions on a joint obviously depend on muscles, but it also depends on the shape or type of joint. And what I mean by that is, for example, a ball and socket joint versus a hinge joint versus a plane joint, right? The structures in the joint will influence the actions. So for example, if there's discs, ligaments, meniscus. And finally, gravity plays a role on the actions that are allowed at a joint. And of course, muscles, like we said. So muscles cross a joint and then contract and pull along a line of pull. Often this correlates to the fiber direction. Usually muscles exert a force diagonally, so at an angle. So if there's a force at an angle, that means some of the force is horizontal and some is vertical. So for example, this is a perfect example for rhomboids, let's say. So let's say this arrow is representing the line of pull of rhomboids. So the horizontal or X, so this arrow down here, is showing which action of rhomboids. So rhomboids has more than one action, but which one is being represented by the arrow in the horizontal plane? Yes, retraction. And what about the one going vertical? What motion of rhomboids is being represented by the vertical one? Elevation. Very good. So this is a perfect example of how a muscle can pull on an angle and achieve both the motions or a combination of the motions, or it can pull, other muscles can cancel out one of the actions so that, say, we only get retraction, for example. So muscles can have more than one action. Even at the same joint, sometimes they have actions at different joints because they cross more than one joint. And you guys now get that, right? So if you know the line of pull of a muscle, you know its action. And if you know its action, you can figure out how to stretch it. How do you stretch a muscle? Lengthen it. Yep. How do you do that? Based on the action. Not using it as an antagonist. Do the opposite action. Not reverse action. The opposite of the action. So if a muscle flexes something, how would you stretch it? You would extend. Yeah, the opposite action. Okay. Oh, that's a tough one. Tough one to explain. Okay, what is an agonist? Ah, it's a prime mover, the muscle doing the work, creating the motion, also sometimes called the contracting muscle. What's the antagonist then? The antagonist allows the motion to happen, or the lengthening, controlling muscle. It often performs the opposite motion of the agonist. Stabilizers, fixators. Usually stabilize the origin or hold the origin of agonists in place. Good. Neutralizer. What do you think neutralizer means? What does neutral mean? Come on. Come on, guys. Keeps it at neutral, so what? Along for the ride, or cancels something. Yes, prevents an unwanted motion. So back to the rhomboids, okay, so let's say all we wanted the rhomboids to do was retract. Well, we need to cancel out the elevation part. Would you agree? Because we don't want the scapula to elevate, we just want it to retract. So we need a muscle to cancel out or prevent the elevation. So we would probably have lower trap do that to cancel out the elevation, right? Because it does depression. Now we just get straight retraction. Does that make sense? So the very first thing you guys should do, anytime you come up against something and you're like, whoa, I've never really seen that before, think terminology. Always go to the terminology. What do you already know about that word? And how can you make it relate to muscles, right? Or to this unit? That's how learning happens. You start with what you know. And then what are synergists? Those are the helpers or assistants, and they can assist anything. Good. So this is way back from the introduction unit, right? Do you guys remember? That's where this slide comes from. Okay. So we're going to talk about some muscles at the hip because you already know these, and some of them are going to play a role at the pelvis. So go ahead and fill in this chart. So we want the prime movers for these actions. It's so hard to write on here, right? I know, this makes my day every day. Okay, so hip lateral rotation, hip medial rotation, hip flexion. So you could write in your handout, that's fine. That's fine. You can type them out in the chat if you guys want. You can make your own chart, or you can provide some entertainment and write it on the screen. So in case you're wondering what next year is going to be like, here's a little preview. These muscles have to pop into your head immediately. When we say hip extension, automatically you should know the muscles that do that action. If it is automatic, great. If not, now you know what to work on over your short summer till next year, right? Okay, so we've got, do you guys just want me to do this? Get on with it? But I just want you to know you've been warned. This has to happen immediate. When you're given an action, the muscles that do that action need to pop into your head. Fast, fast. Okay. All right, let's fill them in properly. So, lateral rotation is not the hamstrings. It's P-go-go-Q, so piriformis and your go-go-Qs, and your glute max. Now, the medial rotators are your glute med min TFL. So, would you agree that these two actions are opposites? Yes. Therefore, the prime movers of hip medial rotation are the antagonists to hip lateral rotation, yeah? And vice versa. So you only ever have to remember the prime movers, because then you can just flip-flop them. Same thing with hip flexion extension, right? And AB, adduction. I can't stress enough how important it is that you guys know these right off the top of your head. You'll get there. Some of you are probably already there. All right, so any questions with that? That's okay. You have till next year, but it's coming. You've been warned. You've now been warned. So for muscle contractions, when we say the word contract, we mean produce force. So a muscle is producing force, it's contracting. It can shorten while producing force, and this is called what kind of contraction? Do you remember this? Yeah, concentric. Good. So this is when the insertion moves towards the origin, usually. These are the regular actions by your agonist. So all the ones we talked about, flexion, extension, medial rotation, all those. Now we have a muscle contracting, producing force, but it's getting longer. What kind of contraction is this? Yes, eccentric contraction. So notice that the insertion is moving away from the origin. The muscle is getting longer, but it's producing force. Is this a stretch? Oh! Oh! Is this a stretch? The muscle is producing force. Therefore, it is not a stretch because the muscle is doing work. Ah, so an example. Typical example is doing a bicep curl. Okay, so you're holding the weights in your hands and you bring your forearm up or you bring the weight up. That's a concentric contraction of your biceps. And then you're going to lower the weight back down. Your biceps is getting longer. Would you agree? And is it producing force? because it's controlling the motion. So that's an eccentric for the biceps. Yeah, it's still holding. So on the way up, it's concentric contraction of biceps. On the way down, eccentric contraction of the biceps. Otherwise, you just drop the weight. But yeah, lowering yourself from a pull-up bar would also be eccentric contraction. Very good. Okay. So, is it a stretch? No. Okay, good. No's across the board. Okay, very good. So this is the typical one where people go to stretch their neck and they just tilt their head over. Well, is that stretching your neck? No, because those neck muscles are actually working to keep your head from falling over. It's an eccentric contraction. All you got to do is lay on the floor, get gravity out of the way. There you go. Okay, good. Now, a muscle contraction where the muscle stays the same length. Oh, so no. All I said there, Liz, was in order to stretch the neck, you need it to not be an eccentric contraction. So I'm going to eliminate gravity so I can make it a stretch instead of a contraction. Now, what about a contraction where the muscle stays the same length? It doesn't change length. What is that called? Very good. An isometric contraction. And what if we keep the same tone in the muscle? Isotonic. Yeah, good. Resting tone, or when we say tone, we usually mean the slight tension that's present in a muscle at all times. So even when we're at rest, our muscles have tension in them, involuntary slight tension. Unless there's nerve damage, then it could be completely flaccid. But normally you have a normal resting tone that's different for every person, but similar. Now, what does RMA mean? RMA, according to muscles. Reverse muscle action, meaning the origin now moves toward the insertion. But technically, whenever a muscle contracts, both the origin and the insertion is moving. Just one moves a whole bunch more than the other, depending on what you're doing. This concept, the fact that both origins and insertions move, is important for the pelvis and the sacrum unit and so forth. Up to this point, we usually just talk about the insertion doing the moving because it's just too complicated to think about both when you're first learning anatomy. But now that you know your anatomy, we can think about both the origin and the insertion moving. You guys okay with this? What happens if you say no? You guys believe me? But doesn't it kind of make sense in a way, right? Like, it's like the body isn't a solid structure. So both ends will move. So here we go. Oh, here's the same information in a different format because I like to nerd it up once in a while. And now that you guys have been practicing isotonic muscle energy techniques, you know that at the start, the muscle isn't very strong. Then the middle, it gets stronger, stronger, stronger. Mid-range, it's the strongest. And then it gets weaker again at the end range. Now we're talking about stretching. So we want no force. We don't want the muscle to be generating force here. So that's how we know it's a true stretch, when the muscle isn't doing any work. So passively, we can use a wall, or the therapist can introduce a stretch passively to a muscle, so an outside force, or actively, where, for example, to stretch my biceps, I'm going to use my triceps. But I have to make sure that my biceps aren't eccentrically contracting. Haha! Okay, so we're going to talk about each of these, and you guys, oh, you just, well, we'll have to think about that one. We're going to go through this list and see if you guys understand this first. So we're going to talk about them one by one, but you guys are going to put a check mark in the box that you think is correct. Okay, so for the first one is the biceps holding a weight. So all you're doing is you're standing, holding a weight stationary with your elbows flexed, okay, at 90 degrees. So what, and yeah, there's no motion. So good, you're all putting the check mark in the proper spot. Very good. So notice the muscle is producing, someone had to go outside the box. Is the muscle producing force in this case? Yes. Is it moving? No. Therefore, it's staying the same length. What about, now we're going to lower that weight down. So that is going to be, very good, eccentric contraction, because the biceps is producing force, controlling the motion. What about lifting a weight with the biceps? Okay, good. Concentric, that one is kind of easy, hopefully. Now, you're standing, okay, hold on. You're against, your toes are propped up against the wall. What is your soleus doing? You're not pushing against the wall. You're doing a passive stretch. You're using the wall to stretch the soleus. That's why we have to go one by one, because I need to explain what these mean. Now we're going to use our soleus to lift our heels off the floor. Yeah, concentric. Now we're going to lower our heels back down to the floor. What's your soleus doing? Yes, eccentric. Oop, shoot. Ha! But do you guys understand this one? So we're going to lift our toes off the floor. What's happening to our soleus? This is an active stretch. We're using our dorsiflexors to stretch our plantar flexors. Aha! Just like using your triceps to stretch your biceps. Now we are standing on our toes. What's our soleus doing? And we're not moving because we're ballerinas. And we're good like that. Oh, that's an isometric. Same length. Now we're standing straight and we're going to bend forward. What's happening to our hamstrings? We got two boxes here. No, it's eccentric because your hamstrings are controlling how far you go forward because they attach to your pelvis. So they're stopping the pelvis from rolling forward. So it's an eccentric contraction. Does it feel like a stretch? You better believe it. What's an eccentric contraction? Now instead, we're going to stand up and raise our leg so it's on a low stool or a higher stool maybe, or a table. That would be a passive stretch for the hamstrings. Not bad, you guys. It's a tough one, hey? Okay. Well, that was fun. Questions with that? So you guys need to think about this when you're assigning stretches to your clients. You need to especially be able to apply passive stretches when you're doing treatment, right? So there you go. Okay. So now we are getting into the muscles. Muscles that attach to the pelvis, specifically the innominates. Here are the muscles. Ideally, all of these popped into your head. So, okay, so lowering yourself off of a step with your heels hanging down would be a passive stretch for what muscle? So our soleus, what is preventing you from lowering even farther to the ground? Your soleus gastroc. They're actually preventing you, they're controlling how much you lower. So is that a stretch or an eccentric contraction? It's an eccentric contraction, so it's not a stretch. Right. Now, there is benefit, of course, there's benefit to doing eccentric contraction, but if you're trying to assign a stretch, then assign a stretch. If you're trying to assign eccentric contraction, then do eccentric contraction. You just need to be able to figure out which one you want and what to assign. Okay, so these abdominal muscles are the only muscles we have left to do in the body, the ones because we don't do facial muscles or intrinsic muscles of the hands or feet. Otherwise, we've done all the other muscles on this page with the exception of the abdominals. But all of these muscles attach to the innominants. So does sartorius. Latissimus dorsi attaches to the sacrum. So does piriformis. Psoas plays a role. Erector spinae, namely iliocostalis, which is already listed. Multifidi and rotators go to the sacrum. So, there's a lot. But you notice the majority of them have to do with the hip. So we've got transverse abdominis. So this is the deepest abdominal muscle, attaching from the iliac crest and the lower 6 ribs and the thoracolumbar dorsal fascia, wrapping around from each side to attach to the linea alba, which is an aponeurosis that travels from the xiphoid process to the pubis. Its main job is to compress the abdomen. For example, when we bear down, maybe when having a bowel movement, or when delivering a baby, childbirth. So this muscle acts like a girdle. You know those girdles in the westerns, right? That people used to wear? They kind of wrap around. That's like this muscle. So find some images of this muscle so you get a good idea of how it goes. Then we have internal oblique, the next muscle on top, right? So it's from the iliac crest, the inguinal ligament, the lower three ribs, and again the linea alba, or that aponeurosis that travels from the xiphoid process to the pubis. So it will compress the abdomen, flex the trunk forward, right? Trunk flexion, side bend to the same side, and rotate to the same side. So those are your internal obliques. So if you think about it, it goes from, say, here to the middle here. So it's going to pull like that way. So that's rotating to the same side. External oblique, it starts on the linea alba and the iliac crest and goes to the ribs. So now we're going from the middle. Wow, I can't draw. From the middle to the ribs. So it's going to pull this way. So is that same side or opposite side rotation? Which way do I end up facing? The same side as the muscle or the opposite side? Good. Opposite. We still get side bending to the same side though. It still compresses the abdomen and flexes the trunk. You guys ready for your last muscle? Can you believe it? It's a big moment. drum roll, rectus abdominis, from the pubic crest to the xiphoid process and the costal cartilage of ribs 5 to 7. So again, it'll help compress the abdomen and it'll do trunk flexion. And you got one on each side, right? And there you go. That's bonkers. There you go. That's it for muscles, guys. Now we have to talk about the pelvis and gait. So we're going to be done class for sure by 8 o'clock. We don't have too much left, but this does require your brain power and your focus and attention because it is a little bit, it can be confusing, but we're going to take it step by step. Haha, get it? Gait, step by step? Okay, so there is a lot going on with gait, a lot. And we're going to break it down and just talk about the innominants, how they move during gait, okay? So first of all, let's review. Do you guys remember the kinetic chains? So for example, open and closed kinetic chain. So open was when you're not weight bearing. So your limb, your arm or leg is free to move. It's not fixed, okay? So for example, when you kick a soccer ball, right, the tibia will move on the femur and it'll rotate laterally at the last degrees of knee extension. Whereas in closed kinetic chain, now you're weight bearing. So now your feet or your arms are fixed and your body will move over your feet or your hand or the proximal segment, which is usually your body. So for example, when you go to stand, you're sitting down, but you go to stand. Now your femur will move on the tibia and rotate medially during the last few degrees of knee extension. So you'll notice with gait, we have both chains happening, right? I'm weight bearing, so that's closed kinematic chain or kinetic chain, or the foot is not weight bearing. And then that's open kinetic chain. So both will happen. You remember these kinetic chains or not really? It's okay. It's kind of straightforward, I think. So for example, open chain is for gait is the swing phase. So the hip is extended, the foot can move. So the femur will move in the acetabulum and we will get hip flexion. Closed chain is when we're weight bearing, so the stance phase of gait. So the hip is flexed, but now we're going to plant our foot on the floor. And now the innominate will move on the femur. We're going to talk about this later, but the innominate will rotate posterior. Oh, okay, so we're going to go over each of these. Yeah, and of course, to get smooth motion, this is happening on opposite sides of the body. Yeah, we're not going to get all into that, but yeah, we're going to look at one leg at a time. Okay, so what are we going to do first? Okay, so right now, even in the image, we've got the non-weight bearing leg is our right leg, and the left leg is planted on the ground. Would you agree? Or it is weight bearing. So left, right. Let's make this clear. Okay, good. Yeah, this is good so far. And this, I am going to take you step by step. And this should, you're going to be like, okay, this is easy. That's good. Okay, that's good because we're going to do this step by step. Ha! So the rectus femoris and your iliopsoas on the right are going to contract to flex your hip. Does that make sense? Because that's the actions of those muscles. So we're okay with that. Sweet. Big old check mark. Now, if we're standing and we pick up one leg, our body weight has to shift over or else we fall over. Okay, so the weight-bearing leg, we're going to have our left glute med and our left QL help shift our body weight to the left because we don't want to fall over. So is that okay? And we do this subconsciously, like we don't have to think about it anymore, but it's happening. Okay. Next. In order to flex our hip, would you agree that the right glute max and the hamstrings have to elongate to let that happen? We're getting all yeses here? Okay, good. Boom. So the right innominate rotates forward or anteriorly, and this helps bring our body weight forward so that we have momentum going forward, and this helps us save energy. So this just makes sense for our body, but can anyone tell me why this might happen? What muscle might help cause this, bringing the innominate rotating it forward? What muscle would be best at it? It's one that we're already using, so it's already listed on the page. So we're looking at the right innominate, and something is bringing it forward, rotating it forward. Do you guys know what I mean when I say that? It means the innominate's going to rotate like that. What's that? Rectus femoris? Why might that be? What are the attachment points of rectus femoris? AIIS, 2, AIIS, 2, AIIS, to the tibial tuberosity. So can you see how that line of pull would pull the innominate so that it rotates forward or anteriorly? Good. So it's mainly due to rectus femoris. Then there's a whole bunch of pivoting happening, which is, it's fine. And of course, we don't want that foot to drag on the ground. That would be a waste of energy. So we're going to get our hip hikers, which is QL and glute med, to elevate the innominate so the foot clears the floor so we save energy. Whew. How's that? It is a long process, and we've hardly done one step. We haven't even done one step yet. We've just have our foot's not even on the ground. It's just been moved through the air. There's a lot going on. No wonder it's a little difficult to learn how to walk, right? And how fast do kids pick that up? How fast do they figure that out? Well, we're talking about the innominate bone, and what axes did pass through the innominate bone? What type? So far in this unit, we've only talked about x-axes. Yeah, 4 x's. Right. The one through the pubic symphysis and the 3 at the SI joint. And we're talking about the innominate bone rotating anteriorly around the x-axis. Good. And this here isn't even talking about for like when we this part of the gait cycle, all we're talking about here is the hip and the innominate in this little table. We didn't even talk about the knee or the ankle. It's crazy, right? But we're not gonna, so don't worry. Everybody breathe. Deep breath. You guys are doing great. You got this. Okay. Now, what do we got here? This is the left. This is the right. I think you guys got it. I don't know. I'm having fun. So now, remember, okay, where we left off was our foot cleared the floor, okay? Like our QL and our glute med helped our foot clear the floor, our right leg, and now we're going to plant that foot. So our weight-bearing leg becomes the right leg. Okay, we've swung our right leg forward. Now we're going to plant it on the ground. So plant our foot on the ground. Phew. So would you agree that rectus femoris and iliopsoas don't have to contract anymore? They did their job, right? So they stopped their contracting. And what motion do we need at the hip now? Our foot is forward now, right, of us, and it's been planted, and now we need what to happen? What hip motion? Hip motion, not innominate motion. Hip, that's okay. This is perfect because now we need to keep separate hip and pelvis. So this is good. So hip motion we need is extension. The hip already flexed. Now it's planted. Now we need extension to happen. What muscles do hip extension? Yes, glute max and hamstrings. And piriformis will help too. So they're going to help do extension, but this is now closed chain. So the innominate is going to move on the femur. So glute max, we see it here attaching, and we know also that our hamstrings attach from the ischial tuberosity to places on the tibia, correct? So which way would these muscles rotate the innominate? Bingo. Now your answer, Angela. Go. Very good. So it was, do you guys get it? I think you get it. You just have to keep hip and innominate separate, just like when we had to keep scap and GH separate. Similar, okay? So there we go. Woof. How are you guys doing? Yeah, I know. It's so, yeah, all of these are great. Yeah. It's tough. Um, I get that your brain, absolutely, it may feel full. I can understand how it feels slow because it's bit by bit, but how it's interesting but frustrating at the same time. Love-hate relationship makes your head hurt, right? So there you go. So the good thing is this is recorded, right? And here's the thing. Here's the thing, you guys. Um, Try not to memorize this. Try to understand it, okay? You guys know the motions of the hip. So what has to happen? What motion brings my leg forward? What motion at the hip will bring my leg forward? Hip flexion, okay? What are the muscles that do hip flexion? Rectus, iliopsoas. Okay. What will rectus femoris do to the innominate? If I look at its attachment points, it will rotate the innominate forward. There. Okay, so at some point during gait, my leg is forward. Okay, I know. Let's do a little tiny bit of webcam. Okay, here's my little skeleton guy. This will help you, right? So, I thought I had it positioned so you guys could see the innominate bone a little bit. Which side? This one. Okay. So we need to bring our leg forward for gait. Would you agree? So we can walk. So that is hip flexion. What muscles do hip flexion? Rectus femoris, iliopsoas. Sorry, guys. Sorry about that. Okay. So rectus femoris and iliopsoas does hip flexion. So if we look at rectus femoris specifically, it attaches from the AIIS, tibial tuberosity. Remember, we said both will move, right? The insertion will move to get hip flexion, but now it's also pulling on the innominate at the AIIS. That will rotate it forward, the innominate forward or anteriorly. So now our leg is forward and it's planted on the ground, and we need to move our body over top our leg. That motion would be hip extension. But this is RMA now because our foot is planted. So the muscles of hip extension are your glute max and hamstrings from the ischial tuberosity, right? So they travel along the back, and they're going to thrust the pelvis over the hip, over the femur, creating hip extension, but also because of their line of pull, they're going to rotate the innominate posteriorly. Done. Okay, so this chart here, can you guys see this? Yes. I want you to bring this filled in for the seminar weekend. Okay, so you only have to do it for the seminar weekend. Review this information, let it fester in your brain, and then fill this in as best you can. Just this one, the actions. And then we'll go over it at the seminar weekend along with the rest of this information. Yeah. And bring a list of questions about the pelvis if you have any. So now, how are you guys doing? I know it's a lot. I know every year it is, but this is the fun stuff that's coming at you next year. Let it fester in the brain, let it stew. And so next class, we have seminar weekend, right? We have presentations from every group. So it'll be a nice review. Then we're going to work on the pelvis unit, picking up where we left off tonight. So bring that chart filled in. We'll go over the actions and we'll go over the pelvis and review. And then we may or may not have time for a quiz, right? Actually, I don't know if we'll have time, but we need to use all that time. We have a lot to do.